All right, so I have to stand over here. So first slide. This is just a few things I'm going to talk about. The pharmacology of opiates very briefly, and then spend a lot of time with the pharmacology of buprenorphine, which is the active ingredient in Suboxone and Subutex. Mainly this entire talk is about how to safely start Suboxone. That is the critical part. And then we'll talk a little bit about, or a lot about, precipitated withdrawal, how to recognize and manage that. Briefly over our Suboxone detoxification protocol. And then we sometimes use Suboxone for induction and maintenance. I'll touch on that. And then there's some issues for disposition and prescription coverage and a few other FYI slides. If we have time, I have a few cases that we can discuss as a group. So opiates, the ones that we think about, morphine, Demerol, Dilaudid, methadone, all of these things are full agonists at the opiate receptor. And I think of a river going through that receptor. So a lot of activity at that receptor. This is the Yangtze River in China, and those are big cargo ships. So just want to impress, lots of activity at the opiate receptor when you get those binding. As we know, opiates give patients pain relief. There's also a euphoria. This activates the dopamine reward system, and it's these are highly reinforcing drugs for abuse and the development of chemical dependence. As we know, opiates also cause respiratory depression and side effects that are common: itching, nausea, vomiting, constipation, and sedation. So you have this big river of activity at the opiate receptor. And what does that do? You take an opiate, you saturate the brain with this river of opiate activity, and the brain responds by making more opiate receptors. And then you take more of the drug, and the brain responds by making more opiate receptors, and more opiate receptors, and more opiate receptors. So over time, you're getting tolerance, which means that you have to take more opiate to get the same effect of the drug. And at some point, our natural endorphins no longer work in our brain, and people who are taking opiates don't get the euphoria or the pleasure or the pain relief from their natural endorphins, and they kind of start to feel bad in general, and they get this blah feeling and don't feel well. So then the opiate is taken in some way to make them feel normal. Use over time of opiates also leads to physiologic dependence. This just means that when you stop the drug suddenly, they're going to go through withdrawal. And you have physical withdrawal symptoms of opiates, and we'll talk about those in a little bit. Something on the pharmacology of opiates and chronic pain. Just as I said, you get this high tolerance. You're increasing and increasing the opiate receptors. The doctor is continually increasing the doses because they're trying to treat the pain. And you may start with, say an opiate-naive person has 10 opiate receptors. Well, those 10 times increase, and then 10 times increase, and 10 times increase. And as I said before, endorphins are no longer working. You have all these opiate receptors, and you have a pain stimulus, and now it hurts more. And there's a lot of patients that end up with this syndrome called opiate-induced hyperalgesia. And we see these patients on our service trying to get off of the regular opiates they're taking onto Suboxone. They're taking very high doses of opiates at home, trying to control their pain. They're sedated, they have decreased function in their life, and really no quality of life. They still can't control their pain. Now, buprenorphine, and what is it, and why it works. So buprenorphine is the active ingredient in Suboxone and Subutex. These are the two things you'll see ordered, Suboxone and Subutex. Buprenorphine is a partial agonist-antagonist at the mu-opiate receptor. And what does that mean exactly? That's very clear for a pharmacologist to understand, but what does it mean to us? Well, a partial agonist means that it only is partly opening that opiate receptor. So we had the full agonist river of the regular opiates, and buprenorphine is a stream, if you think about it that way. So you have the partial agonist, it's a stream, full agonist, river. And the partial agonist is a stream. So when we think about a partial agonist, what does that mean to us? A partial agonist is only activating the receptor a little bit, so this is less than other opiates. It also means that there's a ceiling effect to buprenorphine. You can't more halfway open a door, you can't more halfway open a window, so above a certain dose of Suboxone, you can't get additional effect of this medication. So 32 milligrams is that ceiling effect around there where you take more Suboxone and you don't get more effect. That makes it hard to overdose on sublingual or appropriately used Suboxone or Subutex. It also means that the brain is not seeing this river of activity, this massive activation of the receptors, so that over time, just with this little stream going through, the opiate receptors in the brain downregulate. They decrease over time. So you don't get tolerance, and you can actually get, over time, a decrease in tolerance to other opiates because you have fewer opiate receptors now in the brain. And so someone who's been on Suboxone for a while, who gets off of it and then goes back and tries heroin again at that same dose they used before can overdose because their tolerance has decreased. Other things that are important, it's a partial agonist. It partially opens the opiate receptor. It has opiate activity, and using it over time means we still do get physiologic dependence to Suboxone. That means if you stop Suboxone suddenly after being on it for a while, the patients will get opiate withdrawal symptoms. So that means we need to wean Suboxone or Subutex over time once a patient has been on it in order to prevent the opiate withdrawal syndrome.
So if somebody's been on it for, let's say, a year of maintenance, what kind of typical weaning are we talking about, for a month? Or?
Prolonged a month or 2 months, sometimes longer.
Repeat the question.
So the question was, if somebody's been on Suboxone for a year, what type of weaning protocol would they be on? And this would be, the timing would be, months. After a long period of time, 1 month, 2 months, slowly getting them off it, and it's the end part that takes the longest to get off. And though we use Suboxone for detoxification from opiates, there's no Suboxone detox from Suboxone. So we don't use it for that, but they can use the PRN medications like Robaxin and Bentyl and Clonidine and those things to help them through the withdrawal process. Okay, another thing that makes the partial agonist part of this drug important is that we do use it for detoxification from opiates. So opiates have this high level of activity, Suboxone has this lower level of activity, and withdrawal from opiates lasts 5 days or so from for shorter acting opiates. So we can kind of stop after a day, stop that withdrawal process and cut it off by using Suboxone. Also, being that there's a little bit of activity at the receptor, patients who are using it for maintenance, they have decreased cravings. It fills those receptors, so the fact that the endorphins aren't working don't matter so much. Suboxone provides activity at those receptors, and they go from a low mood to a normal mood again. They have a little bit more motivation, and they can kind of go through their regular activities without feeling the blahs that many opiate addicts would feel after being on them for a long time. The second part of the antagonist and agonist that buprenorphine is, so part 2 antagonist, Suboxone, buprenorphine, it takes over the opiate receptor, and it blocks the opiate receptor compared to other opiates. It binds a lot stronger, so that if someone has been on Suboxone, any other opiate that the patient takes is not going to be effective. It's not going to be able to act at that receptor because buprenorphine is binding so strong to that receptor. This helps Suboxone be a very useful drug for maintenance treatment. it prevents relapse in patients who are taking it every day inappropriately, because if they know that if they take a Vicodin or a Percocet or an OxyContin, it's not going to work while they're on Suboxone. The thing that's kind of important here is, though the buprenorphine has a really, really strong binding to that receptor, if you take enough of another opiate that's very potent, such as Dilaudid or fentanyl, there's a competition that happens eventually with very, very high doses of these opiates, and a few of the opiates will bind if they're potent enough and you take enough of them, so that in an emergency situation where we're monitoring the person on with respiratory rate and all that, and they come in after a very bad motor vehicle accident, or if they need to have surgery, we do have ways to control their pain actually using opiates, and typically we'll use a Dilaudid PCA or intermittent doses of fentanyl, and we can get their pain controlled. So this is not like naltrexone, which is a pure blocker that's very hard to do any of these things with. We can actually treat pain in patients who are on Suboxone maintenance. Some patients have figured this out, which is very dangerous, and I never tell which opiates can be used this way, not to an addict. I just tell them that it is possible. This is similar to the first slide on opiates. So the effect of buprenorphine, it blocks the opioid receptor. Did we miss a slide? Yes, we did miss a slide. Okay, so this is the other part of the antagonist that's really important for us. The antagonist takes over the opioid receptor and will kick any opiate that's there out. And this is really important for how we start Suboxone. So someone has taken some morphine, MS-Contin, and then we give Suboxone a few hours later. That morphine is out of the receptor, we knock it out. And when we're converting from regular opiate, to buprenorphine, the patient goes from this high level activity, and if we give it too soon, to this lower level of activity, and they precipitate withdrawal. So instead of nicely going through a slow withdrawal where we can kind of treat their symptoms, they drop from the 10th story to the 3rd story, and they feel awful. This is precipitated withdrawal if buprenorphine is given too early. And it's a medical complication, and this is what we're trying to avoid. So the important effects of buprenorphine: it blocks the opiate receptor, it knocks other opiates off if they are in there. It does provide pain relief because it has opiate activity. It helps patients return to a normal mood because it's just a partial agonist. It doesn't produce euphoria so much, and it doesn't strongly activate the dopamine system, so there's not as much risk for abuse of it. But it does restore a normal mood, which is nice for maintenance treatment. Question?
Yeah, I was told, and is this true or not, that Suboxone is a short-term pain reliever, that it doesn't work for long term?
It does work for a long term. It has a long duration of action. We dose it multiple times a day for chronic pain, just like we do longer acting opiates will be dosed multiple times a day, but it can be used for years for chronic pain management indefinitely. Side effects that are a little bit different than other opiates. You can get a little bit of hypotension through vasodilation with Suboxone use, and we do see this after we're just starting Suboxone. Blood pressures will drop a little bit, especially when we've been using clonidine and together with it. So that's something for our nurses to look out for. Just like opiates, it causes constipation, it causes sedation if we're giving a too high dose of it. Little old lady who's just taking a few Vicodin a day is not going to need 8 milligram Suboxone a few times a day. That'll be too high a dose. It causes itching rarely, and also rarely it can cause headaches, though it is used to treat headaches as well for pain. It does have a fairly long duration of action, 24 to 37 hours, And that means we can do once daily dosing for maintenance treatment, and we do, after the first day, once daily dosing for detoxification. So how do we safely start Suboxone? We have to go from a river of opiates to the stream of buprenorphine. Remember, full agonist river and a partial agonist stream. So we need to wait until the river becomes a stream on its own. There's no speeding up time or anything. We have to allow that regular opiate to be eliminated from the patient's system so that the remaining opiate activity is less than the level of the activity produced by buprenorphine. And if we don't wait long enough for the opiate to be metabolized and eliminated from the system, there will be precipitated withdrawal. And that's when we give it too early. So there's a lot of things we need in order to safely start Suboxone. Knowledge of the nurses, the staff, the patient's history, very important. The ability to assess the patient and know where they are along that continuum of withdrawal. And then to give the appropriate dose of Suboxone by the appropriate route at a safe time. Also part of safely starting it is reassessing the patient after we give Suboxone. We must reassess the patient after the initial doses of Suboxone, after that test dose, and especially after the first full dose of Suboxone. If the patient gets worse than they were before after these initial doses, they're having precipitated withdrawal, and we need to recognize that. Patient education and reassurance really helps. A very anxious patient needs to know what to expect. Otherwise, their withdrawal is heightened and their demands are heightened. And we need to communicate really well between staff and between the patients and staff and feel comfortable asking questions if we're not sure. So the first thing that's really important is knowing when did the patient take any opiate last. And this is any opiate. So I have a patient who is a 21-year-old gentleman who's taking heroin 4 grams a day, IV and IM. And I hear that from the counselor, and I hear that from the nurse, and I'm going through my history, and I ask every medication when I'm taking a history, and many nurses do as well. I find out the patient took methadone this morning because he didn't like his withdrawal. So even though it may not be their drug of choice, I ask about every opiate that the patient can take, especially these longer-acting medications, because if the patient just took methadone this morning, that's a long-acting medication. Heroin is a short-acting medication. There's a big difference in how we're going to manage that person's withdrawal. I also like to know the exact time of the last dose of each opiate, and I like this clearly recorded in the medical record. The nurses and the counselors are very important for this. Sometimes the physician doesn't see the patient till the next day, and so for communication between staff, having that written down clearly, the last dose was taken at 6 a.m. on this date. People can check to make sure if they're concerned about something later on. We need to know also what kind of opiates the patient was taking, and this is all the opiates. Was it short-acting, intermediate-acting, extended release, or very long-acting? And how was the patient taking each of the opiates, especially in the last few days? Route of administration can change everything. So if someone has been swallowing OxyContin whole, it's extended release, it's fairly long-acting. If someone is injected that same drug, smoked it, chewed it, and swallowed it, or snorted it, it's now a short-acting medication. So it's important to know that.
So smoking it is a short-acting?
Yes. So we'll talk more about that. I'll go into that a little bit more in a couple of slides. We'll clarify that. So short-acting opiates, I left off Demerol here, I think. But it takes, they last about 4 to 6 hours. Duration of action, elimination are about the same, so I didn't go in detail about what is what. But it takes about 4 half-lives to eliminate a drug. You have.
Do you want to explain first what a
That's the amount of time it takes to eliminate half the drug. And it takes 4 half-lives to get it out of the system. So you half it, and then you half it, and then you half it. By 4, it's essentially out enough. It also takes 4 half-lives to get a stable dose of the medication in the system, which is important when you're trying to get a stable level and know where someone is. But for our purposes, we more care in this situation about how long it takes to get out of the system. So if you have something that lasts 4 to 6 hours, multiply that times 4, you get 16 to 24 hours. So 4 half-lives to eliminate it. It goes down and then down and then down and down. The short-acting opiates that we see are hydrocodone, and its brand names Vicodin, Norco, Lortab. Vicodin is 5 milligrams strength, Norco and Lortab, I believe, are 10. Then there's oxycodone, which is Percocet or Roxicet or any kind of generic brand that they're calling it. There's tramadol, which is Ultram, hydromorphone, which is Dilaudid, heroin, immediate release morphine. Demerol should be on here also, it says short-acting. And then I have at the bottom, smoked, snorted, chewed, or injected OxyContin, and smoked, snorted, chewed, and injected MS-Contin are on there also as short-acting opiates. So the root changes everything. Someone who's been smoking OxyContin and then suddenly takes it the day that they get admitted, swallows it whole, again, that changes things. So we want to know the root of the last dose or the last few doses. Intermediate acting opiates. This is a new one. And there are 2 types. This is oxymorphone or Opana. Opana comes as Opana, and it comes as Opana extended release. So just like oxycodone and OxyContin, we have Opana and Opana ER. Morphine and MS-Contin, Opana, Opana ER. This one is the short-acting of the 2, but it's quite long-acting. It lasts 7 to 9 hours. That means if we're trying to get it out of the system, we need 4 half-lives. 4 times 7, 28 to 36 hours to get that out of the system and wait to really start the Suboxone or the Subutex. Then I'm going over these longer-acting opiates when they are extended release. So extended release means that it's a preparation that is time-released if it's swallowed whole. So Opana in particular, Opana ER is my first example. It is released over 8 to 12 hours. After it is released, then it is slowly eliminated, and it's eliminated at the same rate that its base, Opana, is eliminated, because that's what it is. So you have 8 to 12 hours to release it, plus the 28 to 36 hours that it takes to eliminate it. That's how long your duration is going to be before it can safely start Suboxone or Subutex. So in this one, we are waiting 36 to 48 hours before starting Suboxone or Subutex, and we tend to err on the safe side, so closer to 48 hours to start Suboxone after Opana ER. Then we have the Contins, again, time released if they're swallowed whole. These also are released over 8 to 12 hours. After that, they are eliminated, just like the short-acting opiates. They contain OxyContin, which is oxycodone in an extended release formulation, will be eliminated over 16 to 24 hours, just like its oxycodone was. And MS-Contin, which is morphine, it's eliminated over 16 to 24 hours. So we add the time over which it's released, plus the time over which it's eliminated. So 8 hours plus 16 hours is 24. 12 hours plus 24 is 36. So we're waiting 24 to 36 hours before we start any Suboxone after the Contins. And we tend to err close, it's more close to 36 is what we typically see and what we typically wait. Then we have the very long-acting opiates. Fentanyl patches. These are the trickiest, I believe, of all of the things we start Suboxone after. So when you have a patch on, the patients, that is usually absorbed over 48 to 72 hours. Patients will change their patches every 2 to 3 days. That's its absorption time. Fentanyl itself is a fairly short-acting medication, but it has a really variable rate of elimination in different patients. It can be from 3 to 12 hours to eliminate it. So 3 to 12, you multiply times 3 or 4 anyway. So it's a big difference how long fentanyl leaves somebody's system. And then you have this broad range of absorption, 48 to 72 hours, and what are we dealing with? 50 to 108 hours is just a very big range. So in our experience, really it's the time that we remove the patch. And it takes 3 or 4 days before we can safely start Suboxone after removing a patch. It can take longer. It can take longer, and it's individualized. So we usually wait in these very long-acting situations for symptoms like diarrhea before we will start.
So is the variability only because of it being topical?
Well, it's topical, and so the absorption also is when the patch is on, is when they've done the studies, how long it takes, what's the absorption rate. But how long does it take to absorb? Yeah, how long does it take once you take that patch off to fully absorb into the skin once the patch is off? So that's a little more variable.
What about the people that are, because we've had a couple of patients that have come in and they've eaten it, or chewed it or something. And
so then it's fentanyl. It's not long-acting. It's just then it's a fast-acting. It's fast-acting, so it gets eliminated in more like, on average, 7 hours. So 4 half-lives of that.
Okay, thank you. Because I never know how to treat that.
But it can be very fast eliminated. So 3 hours is the quickest that it's usually eliminated. So it could be 12 hours and someone's in withdrawal. If they're shooting it, some people will do all kinds of crazy things with their patch. They'll draw it up out of their patch and mix it with water and eat it or do something unusual with it. But the long-acting version. The long-acting version that we see usually with our pain patients is the patch that's been on, and then they've taken it off at some point. Now, do they always take it off before they come in? No. Do we notice all the time if they've taken it off? No. Sometimes the patients will have a patch on while they're in the hospital because it wasn't caught at admission, or it was noted at admission, but it was a float nurse from another floor who didn't know what we needed to do to safely start Suboxone. So check the patient's body and remove the patch at admit. And if you're taking over a patient who had a fentanyl patch, make sure that there is no patch that contains fentanyl on that patient's body. So back to safe start. It's been about 3 or 4 days, and we do like to wait for diarrhea, which is a later symptom of opiate withdrawal, before we start Suboxone on a patch patient. If we can coordinate their admission really well, it's nice to coordinate with the referring physician, have that physician tell the patient to remove the patch 72 hours before they even come in to see us, and have that physician prescribe them extra short-acting opiates like oxycodone. They can take in very high doses for several days, so that they're coming in here within 24 hours we can start them on something. So there's 72 hours before they come in and they've taken oxycodone as their last medication. We can wait 24 hours and then start something, and we're at the 4-day mark from fentanyl patch, and we're at the 24-hour period from the short-acting opiate oxycodone, and we start very safely in those patients. For the patient who comes in and still has the patch on, they start having withdrawal and they're uncomfortable. And what we've started to do at times is treat the patient with Dilaudid for a couple of days to do what the outpatient person did at home. with consultation with their doctor, we can do that at ARS. And we've started to do that because it's 3 days or 4 days of discomfort if we don't do that. So on to more. Methadone, also very long-acting. And it's so long-acting, 24 to 36 hours. So the half-lives, that's the half-life, and that's the duration of action. So 4 half-lives, to eliminate it takes us out to 4 to 6 days, which is a very long time. It is safe to convert from methadone to Suboxone if the patient is on a stable dose, like at least 1 week, a stable dose of 30 to 40 milligrams a day. That's because of that long duration of action of methadone. If they're on 120 milligrams of methadone a day, it's going to take them a long time to even get down to the level of 30, 40 milligrams a day where it's safe to start Suboxone. Again, Suboxone just has that partial agonist activity, and it cannot compensate or get near what 120 milligrams of methadone is. And it takes weeks, really, for methadone withdrawal to complete. So, whereas for short-acting opiate withdrawal is 5 days, for methadone it's more like 3 weeks coming from higher doses. So this is the studies that they've done. 40 milligrams is what we like for them to come in on. It's important for the counselors to know this. We have taken patients at higher doses on occasion. Sometimes the doctor that's prescribing methadone is cutting the patient off and writing them a real quick taper, and they're desperate, and we will talk to the doctor, we will talk to the patient and educate them and let them know what to expect, and those patients will put on Dilaudid for several days, 3 days, 4 days, so that we can get them, hopefully get more and more of that methadone out of their system and start Suboxone at a safe time. It's worked about half the time in patients over 100 milligrams of methadone a day. About 50% can tolerate Suboxone start, and about half of them have not tolerated it. But for them, we have tried to do this.
Are you frequently confirming with the prescribing physician on the dose of methadone, or are you just taking the patient's word? Because I know in the past we've had patients who actually said they were on 30 or 40, but actually had been on a higher dose, but they knew they just wanted to get in.
If we can, we do talk to the doctor, but it doesn't always happen. And we do trust the patient a lot, no matter which medication that they say that they're taking. Sometimes they aren't telling the whole truth.
Presenting with a complicated withdrawal, or they've been on methadone, is that when you probably contact the prescribing doctor?
If it's during work hours and something isn't adding up, we'll call the doctor, absolutely. Usually the doctor calls the doctor. Yes, Becky?
I'm kind of conflicted about this. I was wondering how you handle this situation. Do you usually reveal that the Suboxone is about 30 milligrams of methadone? Do you usually tell the patient that? Or do you kind of try and stay away from that?
Well, I don't know if I would say it's even 30 milligrams, but because we're going to allow 30 milligrams to eliminate from the patient's system. So it's less. Suboxone is less than 30 milligrams active.
Oh, it is.
Yeah, it's somewhat less than that. But over time, over a 4-day elimination from 30 to 40 milligrams, Suboxone can treat that. So it's somewhat less than 30 milligrams. Suboxone is very potent in that it will bind to all the opiate receptors. But again, it just has that partial activity. So above 30 or 40 milligrams of methadone, we can't convert them safely. So
Are you thinking that because the maximum dose is 32 milligrams of
Right.
Suboxone?
that doesn't match over. So 32
Okay.
milligrams of one drug, 30 milligrams of another drug, there's really no relationship because they're different medications. So 4 milligrams of Dilaudid is not like 4 milligrams of methadone. 50 milligrams of Demerol is not, you can't, they aren't converted in that manner. It's just the particular drug that, again, Suboxone is very potent. That's why we have these low doses. It maxes out at 32. It fills all the opioid receptors at 32 milligrams, but it's only partly activating it. And the partial activation is why you get this difference in activity level. So you can't really equate the milligrams of Suboxone and the milligrams of anything else. But we can say that the maximum dose of Suboxone down here, it's possible to let 30 milligrams of methadone decrease in the patient's system so that we can catch them and decrease their withdrawal safely. Whereas if they're starting from really, really high at 4 or 5 days out, the Suboxone is going to just cause precipitated withdrawal. And we have to wait longer. Yes.
What if the patient doesn't have diarrhea 2 or 3 times, like one of the patients up now?
So we do like, again, we do like to wait for diarrhea for the start. Sometimes that doesn't happen. They don't have diarrhea, and it's going on, and it's now the 4th day, or maybe even the 5th day, and they haven't had diarrhea. They're so constipated from the methadone. At that, sometimes we will individualize the treatment. This is on a later slide, I think. We'll individualize the treatment, and if we start very low dose Suboxone, the 2 milligram doses in several doses, that will slowly get the Suboxone into the patient's system with a lower risk of causing precipitated withdrawal. So you'll see us doing that. That may be in 2 slides, so I'll get back to that. So this is just in brief and in quick summary of generally safe times to start after using these medications. And these are not absolutes. Again, the details were in a few slides earlier, and you can see there's a pretty wide range for each of these. We don't want someone to be suffering and having diarrhea and vomiting if they start to have symptoms in the earlier range of these. And we also don't want to start if the later range is later. But for the Contons, we took the maximum time, and for the short-acting, even 24 hours was the longer time, 36 hours was the longer time, and 48 hours was the longer time for Opana. So again, when we aren't quite sure, we'll wait for diarrhea. And if that doesn't happen, talk to the doctor, say, hey, this hasn't happened, the patient seems uncomfortable, can we start some lower doses?
So it obviously would shorten their stay if they didn't use for, let's say, 8 or 10 hours before they admitted. And so I've been talking to people about coming in mild to moderate withdrawal.
Yeah, 12 hours
But
is nice.
You think 12 hours is good advice?
If they can.
If they can.
8 hours is great. It's what they can do. What sometimes happens is they try to wait the 8 or 12 hours and then they can't take it, and they'll take a methadone. And we definitely don't want them taking the long-acting ones before they come in, because that really does prolong things. Although methadone is a nice kind of gentle way to withdraw. The withdrawal isn't quite as sudden because it's so long-acting. It comes out of the system slowly.
So Laura, so diarrhea is not criteria that you look at in starting Suboxone for the shorter-acting opiates?
No,
at all.
we don't need to push them that far. We really can tell by the severity of their withdrawal and the time that it's been, that it's safe to start. In these longer acting ones, it's so variable. They can look really awful after 24 hours. They can look pretty awful and uncomfortable after 36 hours, and they're not ready to start. So again, that's why we're starting the dilaudid bridge in some of these longer acting ones, because it seems a little bit cruel to cause extreme suffering, unless they can handle it. Very strong stoic people can handle this just fine, but the chronic pain patient who's never even experienced opiate withdrawal is not going to tolerate 4 days without anything. So we're individualizing things. So.
Precipitated withdrawal, are you going to go over
Yes.
treatment?
There's a section on precipitated withdrawal. This is all how to avoid it. So going from the opiates to the buprenorphine, how do we safely start this? We recognize opiate withdrawal, the severity of it, and can assess that appropriately. While they're going through opiate withdrawal, we're giving them as needed medications. We give bentyl, Robaxin, and clonidine. Bentyl for abdominal cramps, Robaxin for muscle cramps, clonidine for the just ucky feeling that they have. And those are important parts of this treatment. Anytime you give a medication, we assess them before and after. And we really want to know if the PRN medications are still alleviating the opiate withdrawal symptoms. That can tell us how far along they've come in withdrawal. And then we always assess the patient before and after Suboxone doses. Blood pressure is important. Are they sedated, or is there respiratory depression? And we want to know what happens to the level of opiate withdrawal symptoms. Again, precipitated withdrawal is opiate withdrawal symptoms that worsen after a Suboxone dose. When they're going through withdrawal, generally, they're getting a little bit worse, a little bit worse, a little bit worse. And we treat that with PRN medications. Once we have given Suboxone, we are looking for worsening of symptoms. That's precipitated withdrawal. It's a complication, and we treat it differently. So we need to recognize it. The MD and the charge nurse get notified immediately if you've caused precipitated withdrawal.
Did the Suboxone help? Now I ask, do you feel worse on the Suboxone? Because
Yes.
that's a better indicator.
Do you feel worse
Yes.
after starting Suboxone would be precipitated withdrawal. So regular opiate withdrawal signs and symptoms. They are dysphoric. They're anxious, irritable or frustrated, depending on their personality. Anger can come out. Dilated pupils, not always, but you'll usually slowly see pupils dilate from pinpoint when they've taken an opiate recently, all the way up to extremely dilated 9 millimeters in very severe opiate withdrawal. They'll get sweats, and they'll feel hot and cold, especially cold, and they have cold chills. Abdominal cramps. They'll start complaining of these at various times. They're mild at first, more and more severe. I like to evaluate the patient's bowel sounds. That can give me a sense of how far along they are in withdrawal. They may say their belly is cramping, but they're very quiet, and they may just be cramping because they're constipated. So bowel sounds are a good indicator for me when they're really in opiate withdrawal. Their eyes are watering, lacrimation. Their nose is running, rhinorrhea. They're sneezing. Sometimes they just sound congested. They have goosebumps intermittently, just mild at first, and a more prominent pylori erection later on. As they're progressing, they get a decreased appetite or no appetite and may be nauseated. They don't sleep. Later on, they do have diarrhea and vomiting. And typically what we see is a patient go from standing up to fidgeting a little bit in bed to curled up and rocking back and forth, and that is the more severe withdrawal. And I'm going to go through that in a little more detail now. So you walk in and the patient is watching TV and they're just hanging out in bed. Maybe they're sitting up. They're a little bit grumpy and they've just eaten their meal and have a little bit of sweat on their forehead. Maybe you notice their eyes are watering, they're sniffing their nose a little bit. They've got like 2 sweatshirts on and you're kind of warm in their room and you've got a t-shirt on. They're complaining of some muscle aches and their pupils aren't really big at this point. And so you give them some PRN medications, the Robaxin, benzyl, and clonidine, and they feel much better now. A little bit later on, you go back in and this, depending on the opiate they were taking, maybe a long time or a short time, their heat is turned up even more. They might have their TV on, but they aren't really paying so much attention to it. They're not really using their laptop. It's just sitting there. They've only partly eaten their food. Again, they might be fidgeting a little bit. One patient might be just laying in bed with a pillow over its head, eyes closed, not really engaged in the world. Another person might be more grumpy and talking out and pacing in the room. They have more abdominal cramping now. The bowel sounds, you can tell that they're increased. Their pupils might be a little bit more dilated. Now we can really see that they're sweating and their skin is moist at the back of their neck. They haven't drenched through their clothes yet or anything. They might have some goosebumps. And they have muscle aches that are now more bothersome, or if they have chronic pain in their back, they may be complaining of their back pain more. We give the PRN medications and they still get a little bit better. This is a different type of patient, a different personality. Same situation. This one is pacing around, calling the nurse, saying, I don't feel well. They can't sit still. They're walking around in their room. They're fidgety in their bed, moving around. They complain more. Their legs hurt. Their back pain is worse. Again, they just have some mild belly cramps and increased bowel sounds. Their sweat is there. They're yawning or sneezing. They've got the runny nose and eyes. And they sometimes get helped by some Vistaril and also just some patient education. Patients come in and they want that quick fix. They want the Suboxone now, and if they're understanding why we're waiting, that can help alleviate their stress and distress. And they still get help when the PRN medications are used. As they progress, they get into that fetal position maybe, and they're rocking back and forth. The room is dark. This is when you get a demanding patient who has just never bothered anybody before. And this isn't a problem patient. This is a patient in severe withdrawal. And they're very uncomfortable and they want help. They can't take it anymore. They may be completely withdrawn with that pillow over their head in their room, and you look in and they're just curled up in bed under the covers with a pillow over their head. They look fine. Well, they may not be fine. So, seeing the changes in the patient over time is important to notice and, assess what you're dealing with. Are they sweaty? Are their clothes drenched? Their bedding is wet? They may now complain of really severe muscle aches. Their abdominal cramps are worse, and they have obvious loud bowel sounds. They're not eating anymore. They've ordered their food. It's sitting there uneaten. The heat goes up and down. And I put this in here, pupils, 2 to 9 millimeters. Some people can be in really pretty severe withdrawal symptoms and their pupils will stay small. They don't all dilate their pupils. Others will have obviously dilated pupils at 9 millimeters. Those are the ones that get the Suboxone. Sometimes we wait a little longer when patients don't dilate their pupils, but if everything else is present, it's the whole picture, it's the whole patient, we have to think that this is really opiate withdrawal, especially you got the bowel sounds going and all these other signs and symptoms. We give the PRN medications now and they just don't help anymore. They may have some diarrhea, feel like they're about to have diarrhea and be very nauseated or start to vomit. And they again have goosebumps. They're larger and more obviously noted.
So which of those stages would be the earliest you would start Suboxone?
Again, you have to take the whole picture and the whole patient. So if it is a safe time to start Suboxone, you have a short-acting medication that they took last 24 hours ago or more, and they look like this, you may be able to start Suboxone. Maybe this is really a fairly stoic patient who doesn't complain a lot too. They can look like more of a moderate withdrawal person, but it's been a really long time, and they're not otherwise sick or have health problems that could delay the metabolism of opiates or anything like that. This is the iffy phase in here. If it's been long enough and they don't look that sick, that's oftentimes when you get somebody else to assess the patient, whether it's a doctor, another nurse, a more experienced practitioner. But if it's been long enough and I've had
Matching both the stage that they're in and also whether it was a short or
their
a
knowledge,
long-acting medication.
and when they last took it. So you need the entire picture for each patient. So just walking in and doing an assessment, you're not going to know whether or not you can start Suboxone. You have to have all the information at your hands. That's why documentation in the chart, that's why communication and sign-outs are really important. Because if you have this picture and someone took methadone 40 milligrams yesterday, you're not going to start it. But if they took oxycodone 30 hours ago, maybe you can start it at this phase. So very important to know who you're dealing with, exactly what medications, and to not have missed something like the patient took 1 dose of methadone yesterday after taking OxyContin smoked for 3 years. So we talked about that. So how to safely start Suboxone. We need to know, again, what is Suboxone? Suboxone is buprenorphine, which is that partial agonist-antagonist. It's a stream, and it blocks the opiate receptor, and it knocks other things out of the opiate receptor. Suboxone also has naloxone, which is Narcan, basically, on that tablet. And it was put on that tablet so that people don't inject it. So Suboxone is a sublingual tablet. We give it sublingually. We don't give it orally, we give it sublingually. And we need to know how to explain to the patient and educate the patient how to take it. It's very important to take it properly. We give it sublingually, and we let the tablet dissolve completely under the tongue. The patient is instructed to hold the saliva in their mouth as long as possible, 4 minutes or so. And then they can swallow the saliva. Once it gets to be a lot of saliva, they can swallow the saliva, but they continue to hold that tablet under their tongue and repeat the process. Sometimes it takes, for the bigger tablets, a little bit of time, 10 minutes or so, to dissolve completely. And they're probably going to have to swallow a couple of times the saliva that they're holding in their mouth. But they want to hold the saliva as long as possible in their mouth, swallow the saliva but not the tablet, and repeat until the entire tablet is dissolved. In this situation, sublingually, buprenorphine is absorbed. Naloxone is not appreciably absorbed or effective. If they take it orally, if you just hand a person a pill, they're going to put it in their mouth and swallow it. That's what we do with pills. So this instruction is really important. And if there's a float nurse covering for a break or something, they need to know this. Orally, Suboxone doesn't work.
So why doesn't it work?
It's not absorbed. It's parenterally absorbed. It's just the way the medication gets absorbed into the system. If you take it orally, I think the liver just takes it out of the system.
And what's the deal with the saliva?
It contains the Suboxone, so you do want to swallow a little bit of that
Okay.
rather than spit it out, so you get just a little bit more absorption. The liver.
That was a mucosal absorption,
It's
not
mucosal.
parental, right?
Well, yeah, it's mucosal, but it's not going through the gut, so it doesn't go through the liver and get taken out of the system. So it gets taken out of the system if you swallow it. And if you inject it, Narcan has the predominant effect. It's a pure opiate blocker. That is why this was attached. Apparently in Europe, where buprenorphine has been around for 20 years or so, people started to inject it and found they could get a stronger effect. And if it's combined with other medications, they were having some overdoses, specifically with IV benzos and IV buprenorphine can cause an overdose. So Narcan prevents that, so we don't get that type of abuse with Suboxone. Of course we have abuse with Suboxone, and I'll talk about that at the end. So when it is safe to be given, we've looked at that whole picture. The time of the last opiate use, what type of opiate it was. We know that it's approaching a safe time to be given. The patient is in severe opiate withdrawal. The PRN medications are no longer working. We give a test dose. We give the 2/0.5 milligram dose. The 2 milligrams is the buprenorphine. The 0.5 milligrams is that Narcan that's there, not really doing anything the way we give it. Again, sublingually, as I said, and have the patient call if they feel worse after taking the medication. And then we're assessing them for that as well. Do you feel worse? So we've given the test dose, and now we're assessing the patient, and they feel better. Just a little bit, but they feel better after that Suboxone dose. Now we're going to give them, after 1 hour, they're still feeling okay. We give them that full dose of Suboxone, the 8/2 milligrams, and that's on our protocol for detoxification. Sometimes, and we're individualizing these for patients more and more now, Dr. Walsh or myself has ordered several small doses sequentially every 2 hours or every 1 hour, every 4 hours be given to the patient instead of our routine protocol. And that's usually with the longer acting opiates that we're really, really trying to avoid precipitated withdrawal in. So if they're improved after a test dose a little bit, we keep giving those doses as they were ordered unless they get worse after any one of those. And if we're starting the routine detox protocol, we're waiting an hour and giving the full dose. What if they have worsened opiate withdrawal after that test dose? That is precipitated withdrawal. We hold any further Suboxone. We do not give any more Suboxone unless the doctor orders it at a later time. You notify your charge nurse, you call the doctor, and get vital signs, report that immediately. The doctor will give instructions at this point. And I'm going to go more into precipitated withdrawal. I just like to mention it a lot in the stage here. What if the patient hasn't changed after an hour? They don't feel worse, but they don't feel better. At this point, I think thinking this is a good point to stop and think. Did you give it too soon? Did you have the right history? You know, just take a moment and look back at things. Recheck the notes and chart notes. Was there any other opiate given? Is there any reason why they wouldn't be better at this time? Could they be getting, this could be the start of something where they're going to get worse. But we check everything and it's the right time. You know, they've been in withdrawal a long time. The patient confirms everything. And the patient could just be in really bad withdrawal where a small test dose is not going to make them feel better. So we can give, if we've, you know, thoughtfully considered the whole case again, we can give the next dose that the doctor has ordered, whether that be a 2.2 and 0.5 milligram dose, or if the protocol is ordered, we can give that full dose of Suboxone. If you're not sure, if you think that you might have given the test dose too early, you can wait a little bit more time, not 8 hours, not 2 days, but you can wait a little more time, you know, half hour, an hour, and see if the patient gets any worse after that test dose. You can have your charge nurse or your doctor go evaluate that patient and think about what to do next. When I'm called about this in the evening, I'll sometimes just order another test dose be given in an hour or two, just to be sure. Unless the patient is obviously has been in very bad withdrawal for a long period of time. Maybe we're starting the test dose later and they just need the full dose of Suboxone before they're going to feel better. But we can take all these other steps in order to safely start Suboxone and keep the patient out of discomfort. The other thing that I've seen a lot of that is not the right thing to do is they give the dose of Suboxone, the patient doesn't feel better, the nurse doesn't know what to do, so an entire shift goes by, and maybe well into that shift it's noted that they got a test dose at 10 p.m. and now it's 9 a.m. in the morning and nothing has been done again. This patient was in severe withdrawal or in pretty bad withdrawal when that first test dose was given, so we don't want to wait a whole other day before we do something else. We've been reassessing that patient frequently and considering what to do, calling the doctor and getting other orders. So, you know, when I say wait additional time, I mean an hour at most, just to see if they're going into precipitated withdrawal with that dose, and then communicating with other people. So if they're in bad enough withdrawal, they should be starting their protocol or getting additional test doses to make sure they're safe.
We're normally waiting an hour
Yes.
anyway.
Yes, we always
So
wait an hour.
Now we're waiting how long?
Now we're being thoughtful. Okay? We're being thoughtful right here. If you've waited an hour and it's the right time and you're sure and you're experienced and you know that the patient, this is fine. If you are uncertain and you think you might have given the test dose too early,
Right.
you can wait a half an hour to see
A
if
half
they,
an hour
an
more
extra
after
half an
the
hour
hour.
more. And you're assessing the patient, you've talked to the charge nurse, you get somebody in.
So we're talking about an hour and a half at this point.
Yeah, it's just a little bit longer.
Okay.
2 hours
I
a
just
month.
wanted a clarification.
Yes,
on
you're
that.
not waiting indefinitely.
No, I
which
understand that.
does happen. People
But we're
wait.
normally waiting an
People
hour,
wait
now we're
indefinitely.
waiting a half hour more than that.
Only if they're unchanged.
If they're unchanged.
Only if they're not, yeah,
If they
oh,
are
no,
unchanged
no, I'm
and
talking
you
about
are
if there's no
concerned.
change.
Yeah, if they are unchanged and you are concerned that
Yeah,
they
we're at
could
a
go into
half-
precipitated
an
withdrawal.
hour and a half.
Just wait a little longer.
Okay.
As an
I just
option.
wanted a clarification.
But probably again, you know, get some other help if that happens.
I've also test dose was given.
Yes.
And then the nurse went back to reassess in an hour, patient sleeping. And she does not give the full dose and the whole shift has
That also happens.
collapsed.
So after that hour, we should be
Yeah.
following the protocol and starting the full dose. If we wait at all because we're worried, we're waiting a short period of time. And we're talking to other people. So action is happening.
But if you think about it, it makes sense because their body's really working hard to try to deal with this.
Yeah.
I love the ones that say, oh, I feel great.
It's easy when we feel great.
Yeah, that makes it so easy.
This is the only one that I just want people to think about it and be thoughtful. So we're the 8 milligram dose. This is the full dose Suboxone. We give it when the patient has tolerated the test dose, or they've tolerated their sequential test doses that Dr. Welsh and myself have ordered, and it's been an hour since the test dose. So that's when we start, as I said in the last slide. And this is the detoxification protocol right here. So when the patient has tolerated the test dose, we give the full dose. And then we reassess them again. We're reassessing them after that full dose, watching them for a while. The protocol as it goes is 4 days long once we start the Suboxone. That's not to mean that they're going to have a 4-day hospital stay. They may be here for days before they start the protocol. But the detoxification protocol is 4 days. They get the test dose and the full dose on the first day. If they've gotten the full dose before 4 p.m. on day number 1, they get a second dose that day. So day number 1 includes a test dose, a full dose, those are both tolerated, and they get a second dose if the first dose was given before 4. So 9 a.m., they feel awful, their pupils are huge, they're feeling nauseated, they're not eating, they're in that severe withdrawal, PRNs aren't working. Test dose at 9 a.m. I feel great. Full dose at 10 a.m. I feel so much better, I feel fabulous. Then over a few hours, they start to feel a little worse again, just not quite to the level of withdrawal they had before. So still better, but it's tapering down, the improvement. And then that first day, since we gave the first full dose before 4 p.m., they're going to get a second dose at 8 o'clock p.m. And that's ordered on the protocol. And this dose is automatic currently in the system. It's ordered. After you give this first full dose, you get to fax the second order sheet for Suboxone down to pharmacy, and then the daily doses will be there for day 2 and 3. If you don't fax that order in, then the next day there'll be nothing ordered for Suboxone. So when you start the Suboxone successfully, you fax the order sheet. And then each day for day 2 and 3, they get a full dose just in the morning. And then on day 4, they get a half dose given. So they get 2 tiny tablets, which adds up to 4 and 1 milligram strength. So sometimes we decide to put the patient on Suboxone maintenance, either for chronic pain or for treatment for addiction. And we usually just allow them to start by the protocol, because that's written very clearly, it's very understandable. And then nurses wonder, why on earth are they now taking Suboxone 2 or 3 times a day? Because we always plan that. It's just safe to start Suboxone through the protocol and then to afterwards switch to twice a day or 3 times a day dosing. And that's, again, individualized for the patient based on their previous treatment history, their risk for relapse if they're being treated for addiction, or it is for chronic pain. So, again, we've given that first 8 milligram dose. We're looking at the patient afterwards. What are their vital signs? Is their blood pressure stable? Did it drop? Are they sedated, or is there any respiratory depression? And again, the level of opiate withdrawal. This is important over about 4 hours. Precipitated withdrawal, Usually happens within 4 hours after starting Suboxone full dose. You're more likely to precipitate withdrawal after that big dose than you are after the little test dose. So really watch after this big dose. Usually it's going to happen within a couple hours, but it can happen a little bit later. If they are improved, we started successfully. If they are better initially and for several hours, and then slowly they start to feel withdrawal again, that's not precipitated withdrawal. But if they feel worse than they did before they started the Suboxone, that's precipitated withdrawal unless proven otherwise.
I have a question. Blood pressure. How low is too low? 80s over 40s, 70s over 30s.
70 over 30 is too low. Yeah. You know, in a young, healthy person, 80s over 40s may happen, but anytime you have a low blood pressure, you want to ask yourself, why is this person having a low blood pressure? Is it because of the medication that we gave them? Is it because of a combination of medication we give? And in this case, often we're giving the clonidine and then the Suboxone. So if you've checked the blood pressure before the Suboxone, hopefully you will avoid the really low blood pressure. If their blood pressure is 80 over 40 before you give the Suboxone, that may be too low. Wake them up, give them some juice, some water. Do they have an infection? Are they dehydrated? Other reasons for having blood pressure need to be assessed, and they'll improve with fluids most often. But you know, we do have patients that have abscesses from their heroin use and have more systemic infections, or they have pneumonia because they've been living out on the street and haven't been doing well. So just, you know, think about everything, but Suboxone will lower the blood pressure a little bit. That's here. So precipitated withdrawal. Is any worsening of opioid withdrawal symptoms after that initial Suboxone dose, either the test dose or several test doses or that first full dose, you can get precipitated withdrawal. And this is the Sears Tower. And I put this building on there because it has these nice levels. And the way I like to think about, again, Suboxone and opiates are opiates high level, Suboxone a lower level of activity. And so as the patient is going through withdrawal, first they start up here with their opiates. And they go through withdrawal, they start going down the stairs. And they're going down the stairs, time is passing, going through withdrawal normally. And they get down to this level, and they're going down the stairs all nicely. And then we give Suboxone too early, and they just plummet. So they jump, you know, from one level to the next when we precipitate withdrawal. So that doesn't feel good. You might see the patient drop to their knees, writhe around on the floor, crying. They're extremely uncomfortable. Or they might just say, I feel worse. The I feel worse is really important. Do not ignore this. And we can start management at earlier signs if we do this. So precipitated withdrawal, we've given it too early and just dropped them down to a level. That's my favorite ring ever. So precipitated withdrawal, how do we manage it? We do not give any more Suboxone for a while. The charge nurse is notified, the doctor is notified, vital signs are obtained. The way we treat precipitated withdrawal is by giving Ativan. This helps the patient be more comfortable. It helps them forget. One dose of Ativan is not enough because this can take a while. We need to, this is now a medical complication, and the patient needs frequent assessments, frequent dosing to keep them comfortable. Again, the patient may be so uncomfortable, they're under their pillow, under their covers, and someone on initial glance may think they're sleeping, but they're miserable. So we need to ask them how they're doing and assess them frequently once we've precipitated withdrawal, because it takes time for precipitated withdrawal to end. It's the same time that we were dealing with before. That opiate has to get out of the system. And the Suboxone has to unblock those receptors, both of which take a long time. So Ativan, you may need frequent doses, and it may need to be aggressive. They may be throwing up and having diarrhea in their precipitated withdrawal, and they need an IV in, and very aggressive management. And so as needed medications, they will not successfully treat precipitated withdrawal. They can help, but they're not the treatment. So, patient comes in opiate withdrawal. It's been 16 hours since their last OxyContin dose. They were a smoker, but this last time they took it orally and swallowed it whole. And a nurse gave it early. And there was actually a float nurse because the patient's regular nurse was admitting a patient. And so the float nurse gives the dose of Suboxone and doesn't go back and see the patient, or sees the patient and says the patient's doing worse. They're still in opiate withdrawal, so starts giving clonidine and passes that on to the regular nurse, who starts giving more clonidine. And so the patient's blood pressure is 60/20 and a rapid response is called. We're not treating precipitated withdrawal. We didn't recognize it, we didn't treat it. And be careful of clonidine after we give the Suboxone. We don't want to give massive doses of clonidine after Suboxone, and it's not going to treat the precipitated withdrawal. Robaxin and Bentyl are still useful. Yes, Emily?
Need frequent doses. How frequent would that be? Every 2 hours, 3 hours?
Every 1 hour, 2 hours, 3 hours. Again, you and the doctor and the patient are a team in this. And once precipitated withdrawal has occurred, you're checking on the patient very frequently, seeing if they're comfortable, seeing what their respiratory rate is, following their blood pressure and all of that, and asking them how they feel. If they're sleeping very comfortably, snoring, that kind of thing, you can be reassured. But if they're quiet with a pillow over their head, go in and ask them how they're doing. They may need additional doses, and you only know by checking on the patient and seeing how they're doing, and then calling the doctor back for an additional order if they're doing badly. Nobody wants the patient to suffer, and this is where communication between the nurses and the doctors and everything makes a big difference. So this is repetition of everything that I've just said. Early recognition, Ativan may be IV, and they may need anti-nauseants IV. We're waiting the time that it takes for the opiate to get out, for the receptors to get unblocked a little bit from Suboxone. And then after a period of time, we're going to start again, and we're going to give a test dose. For the short-acting opiates, we're going to give a test dose after 4 or 6 hours. Again, for a longer-acting opiate like OxyContin or MS-Contin, it'll be more like 8 or 12 hours after we've precipitated withdrawal, and for the very long-acting, even longer. Sometimes we've needed to start Dilaudid on these patients if they really are very uncomfortable. And that's why we need to know, once we've given the Ativan once or twice, are they doing better? If they're not, we have to think about other actions, including Dilaudid. So the risk factors for precipitated withdrawal, this is from the literature as well as from our experience. And someone who has a high level of physical dependence, they're taking 1,000 milligrams of OxyContin, 100 milligrams of methadone, 8 grams of heroin, their higher level of physical dependence, their withdrawal is worse, and it's worse early, and we can mistake their early withdrawal, because it's so severe, as later withdrawal in these patients, because they withdraw fast and hard. So again, it's looking at that whole picture, and the time is really important. The full dose of Suboxone is a risk. The higher dose we're giving, that means the more receptors are blocked, and the more of that opiate is knocked out. So you're more likely to get precipitated withdrawal with the full dose of Suboxone. Again, very long-acting opiates, it's just this very long range of when it's safe to start Suboxone, so it's harder to tell. And again, the higher doses. The chronic pain patient is an interesting patient that is uncomfortable from the very start. They're uncomfortable at time equals 0. They took their MS-Contin right before they came in, and they're already in pain and already feeling like they're having withdrawal. And so we have to look at, again, this whole picture of the time and everything. They need a lot of reassurance and a lot of education. For all these reasons, they're more demanding, fear and intolerance of pain, and they're not used to withdrawal. And they expect medical cures to all of their problems because they're medical patients. They aren't the addict who's been out there using and has gone through withdrawal 50 times because they ran out of their heroin earlier. These are patients who have had everything prescribed to them and given to them, and they've never been uncomfortable. And likewise, any patient who's really anxious or angry or has unrealistic expectations is at risk because they're going to be demanding more and looking worse early. And then when we are undereducated or inexperienced or overconfident, we can not notice what we've done, start too early, and miss precipitate a withdrawal. Failure of communication can happen between the patient and the nurses, the patient and the counselors, the patient and the doctors, and it also happens between us. Sign-outs are important, and that documentation is really important because whenever I want to know when that person last took a medication, I go right to the patient care section that the nurses have filled out, and I go right to where the counselors have filled in their last dose of that medication if I haven't interviewed the patient myself, and I think that's where staff is going to go to as well. Sometimes when Epic is new, the pharmacists are putting in orders, and I've seen a order for Suboxone 8 milligrams now. Patient last took their OxyContin an hour ago. This medication requires thinking, and that's why I've put a lot of thinking into this. You have to know what you're doing, know the patient, and think before you give a medication. Think after you give a medication, and everything will go smoothly. Well, this is the last slide, I think. We're very close. So if we can manage all this by education, communication, compassionate care, you're asking for help, knowing your limits, and the MDs are doing these individualized orders. We'll use a lot of multiple test doses on patients with longer-acting opiates. And if the patient has been on something really long-acting, we won't even order the detox protocol, so Suboxone can't mistakenly be given earlier. Communication for all of these things, I've said this before. Patient education starts in the pre-admission process. And I've said all of this. If they're anxious or have high expectations or demanding, the patient is at risk. After you give a Suboxone, make sure the patient understands that they should call if they feel worse, that's a sign of something that we need to help them with. Disposition. So just a few things. Suboxone is a DEA-restricted medication. Physicians go through training to be able to prescribe it, both in the hospital and out of the hospital. We will give the patient who's staying on Suboxone a prescription, usually for 2 or 3 weeks, and then they're responsible for finding their own Suboxone provider. We can get this list by Googling buprenorphine physician locator. Click on the state of Washington, and it prints out a list.
There's actually an even better way. If you go to Suboxone.com, on the home page there's a find a doctor, and you put in the zip code, and then they're geographically sorted with the closest to the patient's home listed first.
That's nice too. It's good to know. So Suboxone.com.
Right.
Okay. Most of our chronic pain patients who we start on, we're not going to send to just a general Suboxone provider because that's usually someone treating addiction. We typically send them to Dr. Greg Rudolph at the Swedish Pain Clinic. We send them back to their pain providers if their pain provider is familiar with Suboxone. Patients who are on Suboxone maintenance and are going to go to treatment facilities, the Suboxone has to be an approved medication there. A number of outpatient treatment programs now will accept people on Suboxone, and these are a few of the places that accept inpatient treatment: Highland Court, Valley General, and possibly Lake Chelan. Lake Chelan is harder to get into because they don't call back. For L&I patients can be treated with Suboxone, but it takes a couple months to really get all this into action. They aren't even admitted to our hospital without pre-approval of both Suboxone for maintenance and of the admission itself. Still, when they go home, the caseworker has to be contacted, and they have to do a release of the Suboxone for approval that day at the pharmacy. Medicare Part D covers Suboxone, but it has to be pre-authorized. Usually takes a day to do this. We've done it in an 8-hour day, which takes a lot of work by the doctor and the nurses, but it can be done. The pharmacy will say the prescription's filled. I don't know why, but it's not filled. They just have the prescription that they're looking at in their hands. We actually need to know that the prescription has been dispensed and is ready for the patient to walk out the door with it before we send our patient out. DSHS really is only covering Suboxone if the patient is actively enrolled in outpatient treatment. We need a treatment number, and our counseling staff has the number of our treatment center. That's what we use initially. There's a form to fill out for the doctors, and we fax this to both the pharmacy that the medication is being filled at, and also to DSHS. It usually takes 2 or 3 days for discharge planning for this, and it still seems to add time at the end, no matter how much footwork we've done ahead of time.
Further out.
Yeah, the only challenge is knowing how many times a day the patient needs a Suboxone. So it's hard to get the exact dose the patient will need for discharge planning really far ahead, but it does delay discharge sometimes. And then we need nurses' help. Stephanie has also helped in coordinating this final approval, and it's challenging. I just wanted to, I've mentioned Subutex a few times, but didn't really talk much about it because we use Suboxone so much. Subutex is pure buprenorphine. It's also taken sublingually. Pure buprenorphine is also available IV. We use the sublingual Subutex in pregnant patients because we don't know the safety of naloxone, even in tiny amounts for fetuses. We found through studies that Subutex, buprenorphine, decreases the level of neonatal abstinence syndrome for the babies and once they're born. So over time, the Subutex may actually replace methadone as a treatment for choice for opiate dependence in pregnancy. It's not currently covered at all by DSHS for patients who are still pregnant. So really the time that you're going to see Subutex used is in our pregnant patients with insurance who are opiate dependent. You may see it in a pregnant patient on DSHS if we're planning on tapering it off
So it's only used
while
in
they're there.
patients.
Pregnant patients, pretty much. Some patients are on it for short periods of time, or occasionally we've had to start someone intravenously who has got such severe nausea, vomiting from their opiate withdrawal.
So the difference is that this doesn't have the Narcan.
No Narcan. Yep, just buprenorphine. I had this slide earlier about opiates and chronic pain, the high tolerance that develops in the recruitment of opiate receptors. Suboxone is excellent for this. There's no further tolerance because of the ceiling effect of Suboxone and a decrease in opiate receptors over time. It really improves patients' quality of life. The challenges of treating opiate addiction include the euphoria and the fast onset of a lot of the opiates. It's very highly positively reinforcing through that dopamine reward system. And then you have this, they're on the opiates, it's highly reinforcing, and withdrawal is severe coming off of it. It lasts up to 5 days for the short-acting opiates, and it's really hard for opiate addicts to stop. Getting help can be challenging. We're one of a few places that uses inpatient Suboxone. Outpatient Suboxone is also hard to navigate for a lot of the addicts who don't have access to care. Then relapse risk on opiates is high because patients get the blahs after being an opiate addict. They don't have the endorphins, so they pet a cat, they don't feel good. They play with their baby, they don't feel good. They just feel blah all the time. So there is a place for Suboxone in these patients, both for detox and for maintenance. Uses of Suboxone and Subutex. Opiate detoxification, like we do. Treatment of chronic pain. Whether the patient is got this opiate-induced hyperalgesia, they just are opiate dependent because they have chronic pain without that hyperalgesia. Maybe they're starting to abuse the opiates, running out of prescriptions early. Their doctor is getting tired of them. And it's time to switch before they become more addicted or get into more trouble with the DEA or the law by forging prescriptions or buying off the street. Patients who have other substance abuse issues or dependencies and alcohol alcoholic who's been in recovery for 18 years and has chronic pain now, Suboxone is very useful. It's less likely to be abused or become a secondary dependence for them because they're at risk. Again, maintenance treatment for opiate dependence, they feel normal and function well. It's also good to consider in patients who have failed sobriety after treatment and working the 12 steps and they've continued to relapse. Suboxone can be abused. An addict will abuse anything. It does have a street value. Mainly it's being purchased and used for addicts to self-detox off of opiates. When they can't get their OxyContin or their heroin, they'll take a Suboxone tablet. Sometimes they precipitate withdrawal in themselves and will never touch it again. Other times it works for them, and so they go on and off of Suboxone. They don't have heroin, so they'll take a Suboxone tablet. This is pretty dangerous because if they've been taking Suboxone for a while and their opiate receptors are blocked, they now have this narrower window between effectiveness of the opiate and death. So normally you take an opiate and death is out here. You can take a little opiate and it works, a little more opiate, it still works, and you've got a long way before you might die. Well, Suboxone blocks you all the way up to here. So you take a lot of opiate, like heroin or OxyContin, and suddenly have an effect, but the window between effect and death is really close, especially early on. So some of these patients are overdosing. And so the other reason that they might overdose is they've been on Suboxone and they're taking their old dose of heroin after a couple of days, and that dose is now too high because they have decreased opiate receptors and decreased tolerance. So they can just, inadvertently overdose by going back to their old use. So they need the high dose of opiates initially, if within the first 24 to 37 hours after they've taken Suboxone, and after that they need lower doses, much lower doses, because they're not as tolerant anymore.
So is overdosing on the rise?
Yes,
Okay.
it has been.
From the Suboxone and the opiate use, right?
That has been reported, yeah.
Yeah.
I would think that'd be especially true if the people are doing what you say, where they're doing it themselves out there on the
They're
street.
doing it themselves out there in the street. They're not following directions. They're not taking the Suboxone appropriately, and they're not taking the other medications appropriately. They're abusing it.
Change the subject just a little bit on something I don't understand, and
Yes.
And that is, if opiates, OxyContin, which a lot of doctors are prescribing, and I guess when I went down to Louisiana, with the Red Cross, I saw a lot of prescriptions with that. If it's so addicting, why do doctors still use it?
Because it's so effective to treat pain.
Do we not have anything else that?
There are many other medications for pain, but OxyContin is very effective for pain. And a lot of doctors, most doctors are not trained in this. They're not trained in addiction. They don't see the patients that they give OxyContin to and the suffering that it can cause. They don't see the end result.
It just seems like such a shame when it's so highly addictive. Thank you.
It is, yeah. And it's really the main thing with OxyContin. It's addictive for the chronic pain patients, but it's the people on the street that are buying it off the street that are getting addicted a lot more.
We see a lot of people come in and they say,
They started with OxyContin
yeah, I had
and then
back
chronic pain.
surgery, or I had this or that, and that's what happened to
And they're
me.
just physiologic dependent, and they've been on it for 6 months and can't get off of it.
Yeah.
We do see a lot of that, and they're very easy to simply detox and get back to their life. So.
Thank you.
Can I pause one moment? Can we give Laura a hand?
Yes.
Thank you.
And we can go ahead and stop.
Thank you.
And then still continue.
I was wondering, is there research on how effective the Suboxone is for chronic pain patients?
It's very effective for chronic pain patients, equally and perhaps better than others.
That's hopeful.
It's very helpful, especially for the patients that have that increasing pain, that never-ending increasing pain. Suboxone can stop that process, reverse that process, and treat their pain. Instead of having them sedated and low level of functioning at home, they feel more normal You don't get the euphoria or the oversedation so much with Suboxone. So it really gives people their lives back. And I wish more doctors knew about it and were using it, because it's something that, just may be the future for treatment of chronic pain.
Boy, that's encouraging.
It doesn't treat acute pain as well. That's the one thing. It treats chronic pain very, very well, but acute pain from pancreatitis or something like that, we need to give other opiates on top of it for that.
Okay, thanks.
So are the receptors changed, or are they adding more receptors?
When they're taking OxyContin
Yeah.
and OxyContin and more OxyContin,
Yeah.
they get more and more receptors. There's an upregulation, an increase in the receptors in the brain.
Okay, so I've always heard you and Dr. Wall says that once you stop taking OxyContin, it goes back somewhat to a normal deal, right?
Yeah. If you don't take OxyContin for 5 years, the number, and you don't take anything, you don't take Suboxone, you just stop OxyContin in 5 years, the number of opiate receptors will be closer to normal. We don't know if they ever go back to, the opiate naive state, but they're closer to normal.
Okay, then what's the theory about once an addict, always an addict, once an alcoholic, always an alcoholic? Same premise there. 20 years from now, you'll go back to the use you were used to using 20 years ago. What does that mean?
So that's probably talking about the dopamine reward system more, rather than the number of opiate receptors.
Oh, okay.
So that dopamine reward system is activated, and that pathway is very strong, and that probably doesn't necessarily change over time. So it's a different system than the number of opiate receptors, which is involved in tolerance and all of those things, is different.
So meaning like even after 20 years of not using, once they start again, they would have the same
They escalate
instant
very
craving,
quickly. Yeah.
Or at least quickly. Okay.
Yeah. Whether it's alcohol or other.
So if someone says, I'm addicted to Suboxone, that's probably unlikely.
Well, they are physiologically dependent on it. And, again, there's lay terms and there's our terms. Someone who's been taking Suboxone over a period of time tries to stop it on their own or tries to cut down too quickly, and they'll go through withdrawal, and they consider that addiction. It's physiologic dependence, and anything that's active at the opioid receptor and you take it over time, you're going to go through withdrawal after a period of time being on it. It's more dependence. It's not really.
Craving.
It's not really doing the same thing with the dopamine reward system. I don't know that I've ever seen a patient or heard about patients who are taking Suboxone to get high or abusing it in that way. The abuse seems to be around use of other opiates.
So if they don't have chronic pain, and they're coming off the opiates and just want to get their life back, how long do you recommend they stay on Suboxone before they do it? They wean off that?
So it's very individual. So if someone who's been using OxyContin for a period of time or heroin, they can do just the 4-day detox and be completely off the Suboxone and go to treatment and do abstinence-based treatment and do really well. Alternatively, if they've done that, they've tried that, they've relapsed for 10 times after trying abstinence and been to 10 treatments, then you think maybe they should stay on Suboxone. Maybe they stay on it for 6 months or a year or even longer, similar to methadone maintenance treatment. The person has to get their life back. If they've been on the streets, they may need to be on it longer than if they're upper middle class and are going to college and that kind of thing. Maybe they can just be on it for 6 months to a year to get through that period of the blahs, the low mood, the decreased motivation, and everything that the opiate addiction caused. And then they can try to taper it off over several months to feel better. Yes?
Curiosity question. Because it's the Suboxone's placed under the tongue, is there a taste?
Yes, there is a taste, and it's flavored, but I hear that it does not taste good. Most people don't like it. A little bitter.